Thank you for joining this presentation on Fast Track Discharges Are We Getting It Right? An audit completed in Ysbyty Glan Clwyd Hospital within Betsi Cadwaladr University Health Board. So what is Fast Track? Our healthcare facility utilises Fast Track funding and the Fast Track tool to support the rapidly deteriorating patient entering the terminal phase, which is supported by prognosis for discharge within 48 hours. This funding is based on needs and does not have imposed time limits for eligibility. This tool streamlines the discharge process and reduces paperwork, but there is limited research on when to implement it and how long patients live after discharge. Our objective with this audit was to establish the average survival time of patients discharged with Fast Track funding and to evaluate the effectiveness of the checklist, and where possible, identify if discussions took place with patients and their next of kin. Our inclusion criteria for this audit was to include all Fast Track funding applications from Ysbyty Glan Clwyd Hospital between January 2023 and March 2023. There was no exclusion criteria identified. The image on the left shows the Fast Track medical checklist, which includes discussions with patient and relative others, feelings of care and DNA CPR, amongst other requirements. All Fast Track referrals were gathered from the discharge liaison team for the period between January to March 2023. This included the Fast Track checklist and discharge details, such as the demographics, length of admission, diagnosis, discharge date, discharge destination, and the dates of death, all of which I'll present the results for shortly. We also used this paperwork to identify if it had been communicated to the patient and relative others, in addition to checking electronic discharge advice letters when the Fast Track checklist was not completed fully. On the right shows an example of additional paperwork that's completed in the Fast Track process. The images on this slide show the continued paperwork required for this Fast Track funding. These details include next of kin, diagnosis and prognosis, which should be completed and signed by an appropriate medical professional. The details on this page include the discharge destination for the patient. In total, this audit identified 45 applications for Fast Track funding within a 3-month period between January and March 2023 from Ysbyty Glan Clwyd. 3 months prior also showed a similar trend of 15 applications per month. As previously mentioned, the above information was gathered from the discharge liaison team, specifically the length of admission, diagnosis and discharge destination. The length of survival was calculated using the dates provided from the discharge date and the date of death. Communication was assessed based on the Fast Track checklist and electronic discharge letters where possible. 2 major limitations were identified for this audit, one of which is unfortunately we were unable to procure the hospital notes to look into details of communication with patients and next of kin, including details and explanations of diagnosis, prognosis and expectations of the next coming days to weeks. The other limitation of this audit is that we do not have the means to find out if any concerns were raised by family or relatives during and after the discharge took place. It was decided that contacting families at this stage would be distressing. I will now go on to discuss the results of this audit and what this means. The demographics for this audit can be seen here. The youngest patient was a 32-year-old male, the oldest patient was a 98-year-old, and the mean age is 79.6 years. This pie chart shows the proportion of referrals based on medical, surgical and emergency sectors. Most Fast Track referrals came from medical wards, in particular the care of the elderly wards. Out of 45 patients, 17 went home with support, 11 went back to the nursing or care homes, 3 were provided with a new placement of nursing or care home, 3 went into hospice care, 1 patient went into community hospital, and 10 patients died before transfer was possible. The average length of stay for patients who required Fast Track funding was 18.8 days, but the length of stay varied from less than 48 hours to 60 days. One of the main objectives of this audit was to identify the length of survival following discharge with Fast Track funding, of which you can see the results in the table on the right. 10 died in hospital before transfer was made possible. For the 3 who survived more than 40 days, they survived 47, 56 and 77 days. 5 patients remain alive, one of which is in community hospital with 154 days after discharge. 2 patients are in nursing homes of 144 and 175 days post-discharge, and 2 are in their own homes of 118 and 108 days following discharge. After excluding the patients who died in hospital, the mean survival for following discharge was 15.9 days, and 5 patients were still alive at 90 days. The diagnosis and reason for utilising the Fast Track tool included a range of conditions, including malignancy, organ failure, frailty and dementia, sepsis and infection, stroke, fractured neck or femur, small bowel obstruction, and PE. Out of 45 patients, over 50% were due to malignancy, and the second highest reason for referral was dementia and frailty and sepsis and infection. Another objective of this audit was to identify the effectiveness of the Fast Track checklist and, where possible, identify if discussions took place with patients and the next of kin. Out of 45 referrals, 25 had completed the Fast Track checklist, 8 had not completed the checklist, and 12 were unavailable. Communication with the family and the nature of the discussion is unclear from the Fast Track checklist, as there is only a tick box option, and as previously mentioned, we were unable to obtain patients' notes to check medical documentation. Where possible, electronic discharge letters were checked, and some mentioned discussion with family. However, for those who died in hospital before Fast Track could be finalised, an electronic discharge letter was not completed. In some Fast Track checklists, it was noted that the discharge liaison nurses were to or had spoken to family and were to lead discharge planning. So what did we gain from doing this audit? For one, it's an area of limited research, and it's highlighted the need for further improvement, particularly into communication and expectations after discharge. As clinicians, we discuss diagnosis and details of admissions with patients and the next of kin on a daily basis, but it's imperative to be part of open and detailed conversations regarding prognosis, why Fast Track funding is necessary, what to expect in the coming days, and the type of support that is available once discharged. The responsibility should not be left solely to palliative team and the discharge liaison service. It is crucial for medical teams to engage in empathetic and detailed discussions with patients and their relatives, including prognosis and ensuring good documentation to follow. Another outcome of this audit was that we found patients survived on average 15.9 days. However, after excluding the patients who died in hospital, around 14% of patients were still alive at 90 days. This demonstrates that patients survive a lot longer than a few weeks. And thus, expectations of what's to come following discharge needs to be managed accordingly. Lastly, the need for better documentation in the Fast Track referral checklist and in discharge letters. We concluded that electronic discharge letters should detail a patient has gone home with Fast Track funding and why it was indicated. Thank you for your time, and thank you for listening.